مساء الخير، أهلا وسهلا بكم في محاضرة هذا المساء بعنوان Bipolar Affective Disorder. يقدمها الدكتور محمد أمين الحيحي، استشاري الطب النفسي في المملكة المتحدة. تفضل دكتور أمين.
شكرا جزيلا دكتور وليد. آه، أتمنى للجميع أنهم يستفيدوا من هذه المحاضرة، وحكون سهل جدا يعني في تقديمها. خلال المحاضرة حيكون في نقاش طبعا، وحيسهل علينا فهم الموضوع بشكل جيد. آه، في البداية لو سمح لي الدكتور وليد يعني أني أهدي هذه المحاضرة للأستاذ الدكتور محمد فخر الإسلام، الذي انتقل إلى رحمة الله يعني في الأسبوع الماضي. الحقيقة أنه كنت أنا أعمل في التريننج بعد ما تخرجت من كلية الطب، ولاحظت في إعلان في الجريدة آه، كلية الطب تبحث عن طبيبين آه، ما عندهم خلفية معينة في الطب النفسي من ناحية العمل. يعني أحد الشروط اللي كانت موجودة للعمل إنه ما عملوا في الطب النفسي سابقا. ففعلا قدمت أنا وزميل آخر إلي في للوظيفة، وعملنا مقابلة مع الدكتور فخر الإسلام وأحد الزملاء الآخرين، وقبلنا. وعملت مع الدكتور فخر الإسلام لمدة 3 سنين. بعد هاي ال3 سنين قال لي خلاص، يعني أنت استفدت اللي ممكن أنا أعطيك إياه، وهلا ممكن تنتقل إلى المرحلة الأخرى في البوست جراجويت ستاديز يعني. رحمه الله. الباي بولار افكتيف ديس اوردر يعني كإلنس كديس اوردر قديم بقدم التاريخ. يعني الجريكس كانوا يسموا ميلانكوليا، اللي هي عبارة عن، لو نترجمها من اللغة اليونانية، بتكون عبارة عن الدارك أو بلاك بايل. وهذا يعني كانوا يوصفوا الدبريشن، ميلانكولية، أيام هيبوكريت وقبل هيبوكراتس. في جين بير فيرال، في الفرنش سايكاتريست، درس الموضوع بشكل آه، طب نفسي، يعني كان طبيب، وذكر موضوع السيركولار انسانيتي. سيركولار يعني من حكاية الدورة، إنه يكون مرات في هاي ومرات يكون في لو. لما إجا إيميل كريبلين في 1900، الجيرمان سايكاتريست، he is the first يعني who studied the bipolar affective disorder in more details. وزي ما بتعرفوا تكلم كثير عن موضوع الديمنشيا بريكوكس، اللي هي موضوع سكيزوفرينيا، وعن المانيك ديبريشن سايكوسيس أو مانيك ديبريسيف إلنس، اللي هو كان يقصد فيه البايبولار افكت ديس اوردر. كارل يونغ بعد كم سنة كمان تكلم عن بايبولار 1 وبايبولار 2. بعدين اجى موضوع الليثيوم من جون كيد في أيام الحرب العالمية الثانية، اللي ساعد طبعا في to address the affective disturbances. وكارل يونارد كمان تكلم عن اليونيبولار and bipolar disorder. وبعدين الاي سي دي 10 والدي اس ام اخذوا الموضوع بشكل جدي، ووصفوا المرض بموضوع المود ديس اوردرز، مود ديس اوردرز او افكتيف ديس اوردرز. طبعا زي ما بنعرف انه في تعريف البايبولار characterized by periods of deep, prolonged, and profound depression that alternate with period of an excessively elevated or irritable mood known as mania. يعني في عنا mood disorder. يعني لما نتكلم عن bipolar affective disorder نتكلم عن mood disturbance. المود في dichotomy، وان جهة فيها الدبريشن وان جهة فيها المانيا. When we discuss about bipolar, we need to have at least 1 week history of a profound mood disturbance، يا إما elation أو irritability أو expansiveness يعني elation. وهي هي الموضوع الجيت واي to take you to address the bipolar affective disorder أو mood disturbance. At least it should be 3 of the following symptomatology: grandiosity, diminished need to sleep, not sleep disturbance. البيشنت دايما يعني بيوصف الحالة بأنه ما عنده حاجة للنوم. pressure of speech بيكون فيه talkative. بتشوف انه الفلايت اوف ideas between one idea and another يعني racing thoughts. بيكون distracted. excessive work. بتشوف انه في بعض المرضى خاصة الومن مثلا بيقوموا في الليل بيشتغلوا في البيت. كمان حكاية الهايبر سكشواليتي بتكون هاي. وincreased pleasure activity بصيروا يوصفوا بالضبط يعني ايش الاعمال اللي بدكم يكونوا فيها مشان increase their pleasure. هاي السيمتوماتولوجي اللي بتكون طبعا dysfunctional في الديلي لايف activities بتوصل لمرحلة المانيا. لكن في صورة من hypomania where all these symptoms are not severe enough to cause impairment in psychosocial functioning and not associated with psychosis. يعني لما تكون في elated mood does not interfere with their quality of life from day، يعني they go to work, they function and there is no psychosis. هاي المرحلة بتكون hypomania. لما نحكي عن bipolar affective disorder definitely we need to consider also the depression. Major depressive illness or disorder, usually you need to have 2 weeks history of 5 or more of the following symptoms: depressed mood, feeling low in mood, marked loss of pleasure in daily activity, significant weight change due to appetite disturbance، يعني loss of appetite, loss of weight. في بعض المرات بيكون في increase of weight. insomnia or hypersomnia في depression. Usually more frequently بيكون في insomnia but some occasions بيكون في hyper يعني sleeping too much. Psychomotor retardation or agitation. The loss of energy or fatigue. Feelings of worthlessness or excessive guilt. Decreased concentration and preoccupation with death or suicidal thoughts. These are 5 or more of these symptoms. They can indicate a major depressive episode. If we look at the pathophysiology of the bipolar affective disorder, definitely a lot of studies has been conducted within the families, within the twin studies, adoption studies, and all indicate that bipolar has a significant genetic component. The genetic component of bipolar is a complex one. because they have been from 1960s and 70s. WHO have done a lot of studies, including many countries around the world, and they have collected bloods. And I remember in 1980s, there was the center of the collection was in Moscow, where they were studying a patient who has bipolar affective disorder, but they have taken blood from other members of the family, including the parents. And definitely they found some abnormality in several alleles to the chromosomes. However, the conclusion was that it's a low degree risk related to the susceptibility of having bipolar affective disorder. The major affective disorder loci, which we call the genome of the chromosomes, they have been linked to inheritance of specific kind of chromosomes, like chromosome 6, for example. These allocated chromosomes, they are different genes and chromosomes, and they are different from one region to another. They found different kind of studies, different findings in, for example, in India, from India to China to Pakistan to Russia. However, in the West, they have been identified. Chromosome 6 could be the most responsible chromosome in bipolar affective disorder. However, it's not really fully confirmed. In 2007, there have been this kind of study on the genome-wide association, and they shared genetic bases related to the abnormality of some of the chromosomes. There were a high number of studies have been done on these patients and their relatives, around 33,000. And they found that there is some association not only in relation to bipolar, but also to schizophrenia. So the chromosomal abnormality that they found could be also related to schizophrenia and major depressive disorder as unipolar, and also to ADHD and autism. So it's not really a conclusive kind of findings regarding the chromosomal abnormality. If we look at the etiology of the bipolar affective disorder, definitely as any other psychiatric or medical condition, we need to consider the genetics, the biochemical, the psychodynamic, the environmental. There have been a lot of studies on the first degree relatives, and they found that with bipolar 1, they are 7 times more likely to develop bipolar affective disorder 1. So that will conclude that bipolar 1, it's more having the risk of genetic kind of factor related to the illness. Lifetime risk of developing bipolar disorder, the first degree relatives, when we talk about the first degree relatives, parents, siblings, 11%. But when we talk about the dizygotic twins, the risk increase up to 20%. But people who have monozygotic twins, the bipolar affective disorder is more common. The risk is around 80%. Identical twins, they share 100% of their DNA. So this is the risk factors related to the genetic, which is common in bipolar affective disorder, especially when we look at the twin studies, monozygotic twins studies. There is a longitudinal study found manic or hypomanic episode were a diagnostic factor for the development of subsequent manic episode in the offspring of a parent with bipolar and or ADHD, impulsive behavior, anxiety disorders, and substance use disorder. And that will give us the indication that the genetic factor is not only in bipolar, but also it might be common in other psychiatric manifestations. Adoption studies prove that a common environment is not the only factor that makes bipolar occur in families. And this was a study where some twins have been fostered and lived in another environment, and these zygotic twins also the same kind of thing, and they found the genetic factor is common despite the environmental differences. In Maudsley, there were a twin studies showed genetic liability was the same for psychosis shared by not only bipolar, but also in schizophrenia spectrum. If we look at the biochemical factors, as you may know, Ricerbine, it's one of the drugs used for high blood pressure. And definitely these people who have been taking Ricerbine in the 60s, 70s, they suffered from depression. And that can indicate the biochemical changes in the brain affecting the individual to develop depressive disorder of biological features. We know cocaine can cause also mania from the clinical practice. There is a study showed that 33% of all with substance use induced psychosis may go on to develop schizophrenia or bipolar. So there is a biochemical factor contributing to the development of bipolar or schizophrenia. Depression is the manifestation of, this is the dynamic kind of approach. With depression is the manifestation of losses. Therefore, mania serves as a defense mechanism against the feelings of depression. And this has been contributed by Melanie Klein. In fact, there is a reaction formation. But I do remember seeing a lady who her husband has been dismissed from work, and she was manic. She appeared to be manic as a reaction formation to the loss of her husband's job. So this is common also, the dynamic within the bipolar affective disorder. The environmental factors also contributing to development of psychiatric manifestations like pregnancy. We know in winter months, for example, seasonal affective disorder. We will look at that a bit later. And there was a study of 730 admissions to acute psychiatric ward that they found that the admission rate for patients with bipolar affective disorder was higher during May, June, July. And that indicates that there is a significant season related to the manic episode. The pharmacological factors also is an important factor. There was a study at the Maudsley between 1st of April 2006 till March 31st, 2013, and they studied all the electronic records of around 21,000 patients, adults, with unipolar depression. So they collected all the information about the unipolar depression and they studied them, and they found the incidence rate of mania or hypomania with this group, it's around 10 0.9 per 1,000 person in a year. And these people, they have been missed, actually. They have been diagnosed with unipolar, but in fact, they have bipolar type 2. The peak age between 26 and 35 years, which fits also with the bipolar disorder. The result shows that antidepressant treatment, if we will give these patients antidepressant, is associated with an increased risk of mania or hypomania. That confirms the pharmacological factor could be contributing to the development of bipolar. If we look at the epidemiology of bipolar, the prevalence is around 1.4%. So approximately around 500,000 of people over 15 in England and Wales, they suffer from bipolar. Bipolar 1, it seems according to the statistics that they are equal between men and women. However, bipolar 2 is more with females, with women. The prevalence in higher social class as well, if we look at the bipolar, people who have higher social class, they are more common. Comparing with the schizophrenia, they are in poor or in social deprived people. 2/3 of bipolar patients have comorbidity of other mental disorders like anxiety, substance misuse, and the impulse control disorder. And the mean age of the onset is between 18 and 21 years. There have been plenty of cases appeared before that, before the age of 18. WHO, in one of the studies, reported that bipolar affects around 1 to 2% of the population and is the 6th most important worldwide cause of disability, bipolar disorder, because it's a chronic and it's periodical and it causes a lot of dysfunction. The twin and family and adoption studies all indicate that bipolar disorder has a genetic component. The bipolar has high heritability, as we have seen. Studies of some of the polymorphs, significant link between the chromosome 6, as we said, and the evidence of the disorder. However, this kind of study is not really confirmed till now after many years of analysis. The peak age of onset is between 15 and 25, according to the WHO. As you can see here, the differences between the West and some other countries in other parts of the world. 10 to 19 or 20% of bipolar patients, they complete suicide. So the suicidal risk is high in bipolar. The average duration of a depressive disorder is between 3 to 6 months, and sometimes longer. The bipolar may exist on a spectrum with ADHD, anxiety, and unipolar. In fact, now they talk about spectrum affective disorder, and that will include some of the ADHD symptomatology. If we look at this list, I'm not sure if you can see it. These are the leading causes of morbidity in England. It's very interesting. Common kind of physical and psychiatric manifestations listed as a leading cause. If you look at the diabetes, for example, is number 8 as a diabetic patient. And you can see the severity of the dysfunction within the community related to this disorder. Low back pain is the first. Yeah. But also bipolar affective disorder here, it's around the 20th or the 21st leading cause of disability. Schizophrenia, number 17. Very common that you may see the patient or the carers or the family, they ask you about the prognosis of the disorder. Am I going to take the medication for how long, doctor? Am I going to have another episode? So you have to be prepared to answer these questions. And that is definitely you need to look at the prognosis. In 2011, there was in UK study suggested that patients with bipolar, the mortality 1 year after hospital discharge was higher than the general population. And that because of suicide after 1 year of an episode of hospital admission. Patients with bipolar 1 are worse than patients with depressive disorder or bipolar 2. 40 to 50% of these patients have another episode within 2 years. And this is very, very important to, once you assess the patient, you need to have a strategy how to ensure that maintenance treatment is there to prevent further relapses to happen or to attenuate these episodes. 50 to 60% of bipolar 1 who are maintained on lithium therapy gain control of their illness. And bipolar 1 symptoms do not occur. And this is also important, indicate that lithium is a good drug for bipolar disorder. 40% will continue to have a chronic condition. That means chronic condition, you will have other complications related to the bipolar, including cognitive disturbance. The cycling between depression and mania accelerate with the age. If you look at the rapid cycling or bipolar affective disorder episodes, with the growing of age, you will find that they will have more episodes and more severe, especially with depression. The poor prognosis, you need to also to look at some other factors like employment history, poor employment history, if they are using other illicit drugs, if there is a history of psychosis or suffering from psychotic symptoms, if the depressive symptoms between the episodes are severe enough to cause dysfunction, and also it's more poor in terms of prognosis in male comparing with females. The good prognosis, definitely, if you have the episode or the episode of short period of time, if happened late age of onset, the first episode happening after 20 or 25, if there is no psychotic symptoms, this is a good prognostic factor. If there is no suicidal intent, this is another good prognostic factor. I work in a team called PathWest, which is about first episode psychosis, and within the program of intervention for 36 months with people who suffer from the first episode psychosis, we consider education, vocational training, and family intervention, and CBT, cognitive behavioral therapy. and we provide support to the family and to the patient and to the carers. And the patient will be in the central care approach. And that means we will address the specific elements of psychosocial needs to the patient. We will provide, or we will address the quality of life of the patient and try to improve their functioning, including studies sometimes, employment. We provide some practical help to them. We try to educate them around the compliance of medication. As you know, a high number of people with bipolar, they don't take their medication. Therapy intervention, and very often you might see during the acute episode of psychosis and with bipolar that the patient remains with residual symptoms of guilt. So you need to have therapeutic intervention related to this issue. Relapse prevention training to recognize the early warning signs, and to address also the physical health comorbidity if they do have. If the patient suffer from physical health problems, including diabetes or high blood pressure, you need to help them to address the treatment. We also include the 21st sessions. There are trained colleagues who are usually support workers trained in this training in 21 sessions. They called Barcelona Group Psychoeducation Program. And these are the list of all the intervention based on, from the introduction about the bipolar, what are the factors, triggering factors to acute episode of mania or depression. What are the treatments? They discuss it with the family, with the patient. And also they talk about the depressive symptomatology and the hypomanic symptoms. So it's very conclusive and comprehensive, the Barcelona Group Psychoeducation. Definitely during the course of the acute episode of bipolar, sometimes you need to consider acute hospital admission. We depend mainly on community work, where home treatment is the major place for treatment. However, occasionally we might need to consider when the patient, they are dangerous to themselves. If they have a suicidal intent and they describe preparing themselves for this event, you need to ensure that they are safe and to protect them from suicide. So hospital admission is indicated. If they are dangerous to others, some paranoid patients, they can describe some individuals who are against them, and they will say, well, before they will kill me, I will kill them. And that's not really uncommon to have this kind of formula. And you need to be able to protect the public also. There is a condition called delirious mania. It's rare, but it can happen. I have seen it a small number, where the patient, they don't respond to treatment and they give you the indication that they are confused, as if there is an organic cause, but definitely all investigation confirm that there is no organicity. It's a functional illness. It's called delirious mania. You give them antipsychotic medication and their agitation, sleeplessness, aggression continue. And very often you might see there are visual hallucinatory experiences with it. This delirious mania usually respond to ECT. Severe psychotic symptoms associated with behavioral disturbance also indicated for hospital admission. If there is a complete dysfunction, social disability, total psychosocial disability, and the inability to function, we see rare cases, mainly of schizophrenia more than bipolar, but it can happen also in bipolar affective disorder. The total loss of control, for example, if somebody is spending a lot of money, their lack of judgment drives them into make contract with others, which can cause serious trouble, not only to themselves, but to the others and to the family. You might need to consider hospital admission to protect them. Yeah. Alternative treatment, it's like the crisis resolution home treatment team is common in UK. But also there are specific centers where patients can attend during the day, and during the day they will have specific kind of social activities, including gym activity or, for example, therapeutic intervention while they are on pharmacological treatment. If you look at the pharmacological treatment for bipolar affective disorder, definitely you can see the list of antipsychotic. And as you know, there is a first generation and second generation of the antipsychotic. However, nowadays they are more common, the second generation of the antipsychotic drugs that we are using. But also they are all of them good, and they respond to treatment, but there are differences definitely between them. And according to the practice, and you can see when to use olanzapine and when to use quetiapine. And there is a difference between them according to the individual who is in front of you, and you are assessing, evaluating the situation, which drug will suit them better, really. Yeah. Also, at the same time, there is anti-manic drugs like lithium and some other anti-epileptic drug used in bipolar affective disorder, like valproate, lamotrigine, carbamazepine. Again, these drugs, they are used, but also they are different in prescribing between one individual and the other. You need to have a specific kind of situation to prescribe these drugs. Benzodiazepine in acute symptomatology of mania, for example, like lorazepam or clonazepam, can be used as a sedative drug to control the situation and to improve the behavior and to induce sleep sometime. There is an international study in Australia and North America and Europe regarding 217 outpatients. And they studied these patients, and they found that all of them, they were diagnosed with bipolar, but 90% of them, they were bipolar 1 and 10% bipolar 2. The socio-demographic data are similar in a way. Female and younger age overrepresented compared to general population. Half reported depression at first episode. Half of this 217 reported first episode of depression. So it's not always you need to have mania to diagnose bipolar 1. Sometimes it can be the first episode of depression and then followed by depression or by mania. But mania, it should be a full picture of mania to diagnose bipolar 1. 40% they had family history of bipolar illness. They noticed that earlier age of onset in United States and the higher number of episodes they are in America, comparing with Australia and Europe. And the less psychotic features and suicidal attempts in Australian patients. As you can see, there are differences between the clinical presentation from one country to another. In our trust, recently in September, on the 5th of September, we have received this warning, advice for patients on valproate to use contraceptive method. Yeah. And they say, if you father a child while you are taking valproate, there is a potential small increased risk of the child being diagnosed with neurodevelopmental disorder. So it's not only the mother, but also the father. A study of health records reported that around 5 in 100 children whose father were taking valproate at conception had a developmental disorder. So the mom was safe. She didn't have a mental disorder, but the father was on valproate, and they had these 5 out of 100 developmental problem. It's recommended that you and your female sexual partner should use effective birth control if you are taking valproate. Valproate is known to be associated with high risk of both birth developmental and neurodevelopmental disorder in children if taken by women during pregnancy. So there is a strict kind of registration now. We do have, if I want to place a female patient of childbearing age on valproate, I should complete a form, and this form needs to be signed by the patient, and this form needs to be renewed annually and sent to the GP also to be aware of this kind of agreement between us and the patient. Seasonal affective disorder. There are plenty of talks about seasonal. There are some colleagues, they don't believe in this kind of entity related to a mood disorder. They consider it as part of living condition, really. However, it has been reported since Hippocrates in the Greek time, first introduced by the Roman Rosenfeld in 1980. The incidence 2 to 4%, and very common in cold countries. We hear plenty of people saying in winter months they feel low and depressed. And they described having hypersomnia, they sleep too long hours, increased appetite, put on weight gain. Yeah. In ICD-10, it's not recognized. In DSM-4 and DSM-5, bipolar 1 and bipolar 2 as a seasonal pattern, but not as a specific entity of mood disorder. You can have, if you want to diagnose seasonal affective disorder or SAD, you need to have 2 consecutive episodes, periodical episode. Like, for example, in May, you have mania. next year in May, you have mania. That means you might be able to consider that this happening due to the seasonal affective disorder. Or in winter months, in February and January, you may have depression. The absence of any psychosocial variables to be able to diagnose SAD. And the depression usually manifests with fatigue, dysphoria, irritability, lack of concentration, hypersomnia, increased appetite and weight, loss of libido, and lack of social interest. Usually in seasonal affective disorder, according to the findings, you will have 30% of hypomania and 5% mania. And the performance usually is poor during the period of seasonal affective disorder. There have been some claims since 1960s about light therapy that improve the patient, and they were common to use the boxes of light during winter months. And usually you can use the SSRI for depression. The rapid cycling is interesting phenomena in affective disorder. There are some claims that a quarter of bipolar patients, they have rapid cycling. And to be diagnosed with rapid cycling, you need to have 4 or more episodes in a year. And these 4, they can be of mania or depression or hypomania or depression. And observed with a reduced response to lithium. Usually this group of patients, they don't respond well to lithium. And it's more common in women, and they respond better in valproate or atypical antipsychotics. One of the things which we do have in UK, when somebody is diagnosed with bipolar, they should inform the DVLA, what we call, which is the responsible agency for driving. And if they have bipolar affective disorder, rapid cycling, they withdraw the driving license from them. Yeah, so very often I receive letters from DVLA making an inquiry about the patient's mental health if they do have rapid cycling. I do remember some time ago, Dr. Walid asked me, how do you differentiate between bipolar 1 and 2? I think this might be able to help just if you look carefully at the factors or the features. For example, if you have somebody who had depression, but also there is a history of substance abuse, I think it's more common in bipolar 2 rather than unipolar depression. If there is a family history, you need to put the chance that they might have bipolar depression or bipolar 2. The seasonality also, as we discussed about SAD, also within bipolar. If the first episode of depression happened before the age of 25, you need to go deeply about the history and find out if there are other factors contributing to bipolar disorder. If they have psychotic features within the depression and they are less than 35 years of age, again, it's bipolar, more within bipolar. If the symptomatology, they are atypical, as we described, having the fatigue, loss of desire, loss of libido, loss of interest in social functioning associated with some other symptomatology suggestive of bipolar. Yeah, that also more of bipolar rather than unipolar. If the illness comes quick and resolve quick, again, it's bipolar. Usually the unipolar or the major depressive disorder, it prolong up to 6 months. These kind of episodes of depression within the bipolar, usually a month or two, 6, 7, 8 weeks. If there is a history of antidepressant-induced mania, I think, as Dr. Walid said once, that we need to go to bipolar. And if the brief episodes, as we said, less than 3 months, again, it's bipolar. Are there distinctive clinical features distinguishing bipolar depression from unipolar depression? As we discussed, again, bipolar is more likely to have melancholic type, bipolar, melancholic type, which is pessimism, life not worth living, social withdrawal, things like that within the melancholic type. The bipolar more likely to have been psychotic, as we said before. Bipolar less likely to be tearful. Very often you see, especially women in tears, and they are depressed. It's more likely unipolar or reactive depressive disorder. Yeah, it's less likely to be bipolar. Less likely to be anxious. Also, the component of anxiety is common in a bipolar. Less likely to be anxious in bipolar. The family history of bipolar, definitely that will increase the chance to have bipolar, and the young age of development of first episode especially is bipolar affective disorder. The course of the illness is also important. The peak age of onset is 15 to 24 in bipolar. The onset usually between 13 and 30. This is according to different studies and different geographical area. As you can see, there are differences definitely between hot countries and cold countries within the bipolar also. If onset occurs above the age of 40, think of an organic cause. Think. That doesn't mean all usually there is organicity as a factor contributing to this illness, but you might need to think about it. And it happens very often that you might end up having a specific kind of physical health comorbidity, which inducing manic symptomatology. Relapsing chronic course is 50% within a year. That's very important also, that you can see within a year you have 50% they have the chronic course of the illness. The 70% within 4 years, they will have the chronicity of the bipolar. More than 90% of people who have a single manic episode will have another recurrent, 90%. Yeah, and that indicates the severity or the dysfunction related to the bipolar affective disorder. The lifetime suicidal risk is around 20%, which is a high risk of suicide if untreated. Yeah. Definitely in bipolar affective disorder, you need always to consider other psychiatric manifestations which have common symptomatology with bipolar affective disorder, like schizoaffective disorder. You need to have a schizophrenia with affective component to diagnose schizoaffective disorder. Also, schizophrenia sometimes can be manifested with bipolar affective disorder. ADHD, there is a common kind of manifestation now of ADHD symptomatology with bipolar or manic episodes. Emotional unstable personality disorder, as you can see, there are specific symptoms related to mood disturbance. And the drug-induced psychosis, we need to be careful about how to differentiate between these four and the bipolar affective disorder. If we look at the treatment in terms of just an idea about how you can start medication, if somebody is manic, euphoria, or hypomania, I think lithium is a good drug in acute and in maintenance treatment. We mentioned about mixed affective state, especially with the seasonal affective disorder. You might see this kind of condition. Mixed people have hypomanic symptoms, but also they have depressive. I think Depakote or Valporate, they are good drug in situations like this. Mania with psychosis, mania with psychotic symptoms, you need to have mood stabilizer and antipsychotic drug, like, for example, quetiapine and lithium. Yeah. If you have mild depression, I think you can stabilize the patient on lithium. You might need antidepressant for a while and then withdraw the antidepressant, start lithium, and keep the patient on lithium. And definitely you need to monitor the lithium blood level and other systematic kind of investigation. If you have severe depression with psychosis, mood stabilizer like lithium, antidepressant like, for example, venlafaxine, and a typical antipsychotic like, for example, olanzapine. An example. Yeah. If we talk about the rapid cycling, as we described before, 4 episodes or more in a year, consider valporate. Depakote is one of the trade drugs for valporate, semisodium valporate. If you have bipolar and alcohol-related problems, again, valporate or Depakote. If there is a treatment resistance, as we have described in delirious mania, ECT, followed by pharmacological treatment based on lithium therapy, will do the treatment on long-term maintenance treatment. Treatment of different phases of bipolar illness. This is just tips, really. Acute manic or mixed episode. If it's severe, I think we need to start antipsychotic generously with antipsychotic medication. If it's less severe, consider lithium. If it's the episode of mania severe with aggression, carbamazepine is a very good drug to control the situation. I'm not sure if you can maintain the patient on carbamazepine for long term, but definitely in the acute stage of severe mania, you can control the situation with carbamazepine. If the episode due to inadequate symptom control and the patient, they are high tolerated the dose offered, inadequate symptom control, again, you need to consider antipsychotic or carbamazepine. If the symptoms are inadequately controlled, with optimization doses or mania severe. Consider lithium valproate with antipsychotic medication. And as we said about the delirious mania, you can consider ECT. In acute depressive episode in bipolar, if somebody has bipolar affective disorder, type 1, and they are severely depressed, and they have been coming to see you, how you will treat them. Definitely, you need to bear in mind that depression, it's an episode of the affective disorder, the same as mania. And the risk of switching, it's there. And you don't need to treat the depression by switching into mania to complicate the situation further. Yeah. So the treatment will be antidepressant and antimanic. Definitely here, you need to be able to decide which antidepressant and which antimanic. Depend on the individual and depend on the clinical manifestations. Antidepressant like venlafaxine, it's a good antidepressant. And antimanic like lithium, it's a good drug. Or a typical antipsychotic monotherapy. And they are referring here to quetiapine. Quetiapine is it's a drug where has been licensed for bipolar affective disorder. Again, olanzapine, I remember in the 90s or early 2000, there have been studies, it's called the EMBLEM study, on olanzapine in bipolar. And they have, following that study, it has been approved that it's a drug for bipolar affective disorder, and it has also antidepressant property. So you can consider monotherapy as antipsychotic drug. Antidepressant monotherapy is not recommended. If you give sertraline to depressed patient who has bipolar 1, within a couple of days, they will switch into mania. If patient is psychotic, add antipsychotic. Now, the situation is, if there is lack of improvement, you need to consider some other form of treatment. If the patient, they are pregnant, a lady who is pregnant, and there is high risk of suicide, you might need to consider ECT. And definitely in this country, to do the things right, you need to have something called second opinion appointed doctor. And that means also you need to include the law within the treatment. You need to assist the patient and to put them under specific kind of sectioning to consider providing this kind of treatment. Antidepressants are less likely to induce mania when added to lithium or valproate. So this kind of fear of the antidepressant switching patient into mania, it can be justified once the patient they are on antimanic drug like lithium or valproate. Now, there is a drug called lamotrigine, which you can consider for bipolar depression if the SSRI make instability of the mood. And we have very often prescribed lamotrigine to patients who have schizoaffective or bipolar 2. Lithium monotherapy is effective against both manic and depressive relapse, although is more effective in preventing mania. I think based on the long history of lithium, it has been now more established that lithium is a good drug in maintenance treatment for bipolar 1, but also in a small dose or in lithium blood level between 0.4 and 0.6. It can be preventive of bipolar 2 or in depression, unipolar depression. Long-term treatment, especially with lithium, reduce the risk of suicide. We know that. People who have schizophrenia and they are maintained on clozapine, usually we add lithium, especially if they are at high suicidal risk. Very low level of lithium in drinking water can lower the risk of suicide, and this has been common and studies have been confirmed in Japan. If lithium is ineffective or poorly tolerated, or there is specific contraindication for lithium, valproate in mixed state, quetiapine and olanzapine prevent mania. There have been some studies, the combination of the quetiapine and olanzapine together to prevent mania. It's not really very conclusive, the studies, but it has been, and also in depression. The carbamazepine is less effective, as you can see, especially we prescribe it in people who are aggressive with mania. There have been cases, very, very agitated states, very aggressive patients with violence, and that carbamazepine for a generous kind of weeks of treatment, it might have a good effect. Lamotrigine, definitely, as we said, to prevent depression in bipolar 2. Lithium and valproate should not be prescribed for women of childbearing potential, and as I described before also, now there is a warning for men also not to use it without consent, without clear program about it, really, because of the risk of neurodevelopmental problems. The side effect of lithium and valproate. Definitely these two anti-manic drugs, we need to depend in maintenance treatment or in acute stage also of treatment. However, you can see the white blood count, it increased with lithium and slightly decreased with valproate. Why this is important? As I said before about schizophrenic patient on clozapine, we know one of the major problems we have, the agranulocytosis or neutropenia. We can add lithium to patients who are prescribed clozapine, and you can increase the white blood cells. Definitely, it's not a very welcoming attitude or practice, but it can help. Just bear it in mind. And it has been reported many times. I used it several times, and it had very good results, especially if the agranulocytosis or neutropenia, if the neutropenia, they are benign, And there are worries about the number of white blood cells. You can add lithium to clozapine, it will increase it. Now, the diabetes insipidus, which is polyuria and polydipsia, you can see it increase in lithium. T3 and T4, we need to be careful about monitoring the lithium, the thyroid function. The TSH, it increase. And if we will ignore that increase while the T3, T4 at normal level, the patient will end up with goiter, hypothyroidism. The serum calcium slightly high in lithium. The weight gain, again, to be honest with you, I am not really very concerned about the weight gain in lithium, not too much, but the patients, they reported it. Tremors, especially in toxicity, or can indicate that there is lithium blood level is not right. It will give you indication. In diarrhea, for example, if you have infection, you need to be careful about the lithium blood level. Yeah. Alopecia, which is the hair loss. You can see it increased in valporate. I can't see you to ask if what kind of measure you might. If a lady, for example, maintained on valporate and she is doing well and she has alopecia, how do you treat her? We can say that later. Again, hepatitis in valporate. In lithium toxicity, as you can see, gastrointestinal, motor, and cerebral. The toxicity of lithium can be serious in complications, and there is the mild, from nausea to diarrhea to vomiting, to severe vomiting, but also the cerebral kind of complications can be serious, and we need to be careful about when prescribing lithium in people who are living in hot weathers region, especially if you are in Jordan during summer months. What kind of measures do you take to ensure that the patients, they will not come with toxicity? Yeah. There's a study of 78 patients with bipolar 1 and 2 patients treated for depression by adding antidepressant to mood stabilizing medication. So they are on mood stabilizer and they added antidepressant. What happened to them? Followed by 6 months. The first group, they had the depression sustained for 6 months. So they had poor response to adding the antidepressant. The second group, abrupt switch into mania. And that acute switch group, 20%. And the third group, the depression improved to euthymia. And this is the majority, actually, the good response group. So adding antidepressant to mood stabilizer, 50%, they maintained euthymia, improved. And the fourth group, depression improved, but manic switching occurred during maintenance treatment. As you can see, there is a variability of the chance of having also maintenance treatment by adding the antidepressant to the mood stabilizer. But this study has been only for 6 months. Delayed group switch, 20%. The conclusion, the bipolar depression has heterogeneous treatment response. The antidepressant should be discontinued within 8 weeks after improving to euthymia to minimize the risk of having a manic episode. The course of the illness, the duration of the episodes, the manic episode lasts between 2 weeks and 5 months. The depressive episode longer, as we can see, 6 months or more, even a year sometimes. Chronic depression, depressive symptoms, and mood stability are common between episodes and the impact on them, on the patient. The rapid cycling, 10 to 20% of people with bipolar. We need to be careful about the rapid cycling also. You need to count and with dates and to give them a mood document to register how they feel from every week, really, or every day even. 4 or more episodes of depression or mania per year can really diagnose the rapid cycling. And often this rapid cycling has poorer prognosis. Here there is this kind of study about the bipolar and the monopolar manic polarity between 175 patients followed up by 5 years, and they found that the monopolar, the patient who had, I'm not sure about the correctness of this study, to be honest with you. I reported it mainly to show that the euthymia in green, it's longer than the acute episodes happening when the patients, they are maintained on treatment. The suicidal attempt reduced, the anxiety reduced, and the psychotic symptoms increased during the manic episodes. Here, the bipolar disorder, the symptomatology in a constant state of flux. We can see euthymia and people when they go up in high during the hypomanic or the severe mania, and mild to moderate to severe depression. And the extreme of exaggerated mood, this is part of the illness in itself where interfere with the functions. The depressive symptoms most common in patients with bipolar 2. Mixed episodes, state of mind, most fragile, and we need to be careful about the suicidal risk during the acute episodes. In the West, politicians and celebrity people, they talk about their psychiatric problems. And this is Winston Churchill. And he says, I don't like standing near the edge of a platform when an express train is passing through. I like to stand right back and, if possible, get a pillar between me and the train. I don't like to stand by the side of a ship and look down into the water. A second action would end everything in a moment of desperation. And this is a man who had bipolar affective disorder. He was the prime minister in the Second World War. Dr. Walid, can you help us in this? The following statement concerning lithium therapy are true. If anybody from the junior doctors wants to help us.
Yes, Safa. ممكن زي الميكروفون ما بزبط
Yeah.
على الشات. صفاء لسان.
تمام، يعطيك العافية يا دكتور.
هلا.
تمام. ال following statement concerning lithium therapy are true. الأولى غلط والتانية غلط برضو. full benefit may be not evident before 6 months. لا برضو thiazide أو diuretics reduce the serum. ممكن دي.
لا، هي كل واحدة بدك تقولي صح ولا غلط.
تمام.
The
الأولى
drug
مش في
is
الليفر، لا لأنه
partially
في
the drug is partially metabolized in the liver.
يعني الليثيوم.
True or false?
false.
Why?
Because lithium is a salt metabolized in the and excreted during the raw kidney.
Right. That's very good.
تمام. B الليثيوم induced
The lithium is an element. It's عنصر. فما بيتعامل، ما metabolized، يعني ما في destruction أو metabolized in the liver. فهو
تمام.
secreted
أكمل
by the
B.
kidney completely. صح. B
الليثيوم
lithium induced
الغلط
hypothyroidism.
غلط لأنه ممكن نعالجها برضه بالثيروكسين، يعني إنه هو مش بس by stopping the drug وممكن نحتاج ندي علاج، يعني قصدي
Right.
لا علاج
So,
اللي هو anti thyroid hormones يعني.
right. So you agree with the fact that lithium induced hypothyroidism.
ألو.
Is that right?
تمام. بعد
Lithium
ثيروكسين
can
لأنه
induce.
حتى بيكون adjuvant كمان في العلاج، غير إنه إحنا يعني.
Right. But the problem is that it can be treated.
كمل ولا؟
Yeah. Okay. The full benefit, it's may not be evident before
maybe not evident before
6 months.
6 months of treatment.
Yeah. Is that right?
مش عارفة، حاساه فولس، يعني أنا هل حد هيوصل 6 months وهو مش متعالج يعني؟
Yeah.
فلو 6 months ما تعالجش غالبا هنفكر في حاجة تانية، يعني هنشوف، مش هنخلي المريض 6 شهور على علاج وما ما تحسنش.
Right.
thiazide
حقيقة إنه
diuretics reduce lithium serum.
yeah, the full benefit of lithium due to the fact that you need to have regular monitoring and
اللي هو
you
عشان
need to
الثيرابيوتيك
have
اندكس.
to ensure that there is no adverse effects of lithium. It needs minimum 6 months. That's true.
ترو. تمام. عشان نوصل برضو
دي
للليفل اللي احنا بدنا اياه عشان نوصل يعني فوق
بالضبط.
6 من 10.
Yeah,
تمام.
that's right. Yeah,
بعدين thiazide diuretics reduce lithium serum level لأنه هو بتأثر في الحاجات اللي بتعمل dehydration ولو بسويتنج وبالجو الحار والحاجات اللي زي كده.
right. So it's right. دي
right. yes. بس لا increase وليس reduce، يعني
بالضبط.
increase yes.
increase.
yes.
Yeah, so it's خطأ. أيوة.
تمام.
بعدين secretion of antidiuretic hormone.
اللي هو anti diuretic hormone اللي هو may reduce leading to polyuria and polyuria اللي هي diabetes insipidus. صحيح.
Right. May be reduced to lead to polyuria and polydipsia. I think it's wrong.
wrong لأنها هي increased. sorry هي increase. sorry.
Yeah. right. طب هاي كان في عندي خلينا أحكي لك القصة.
تفضل.
كان في عندي مريضة عمرها تقريبا 25 years old lady attended A&E in a manic episode. She was manic. She was hyperactive, pressure of speech, flight of ideas. But during the course of the assessment, the police were involved. We understood that the police has arrested her because she was harassing a priest in the church. And she believed that this priest, he was in love with her. And she started to give him gifts, sending him emails, interfering with his job. At that extent that this priest, he reported her to the police. And he said, please, can you help me? I can't manage this lady. She comes to the church and she sits in the first line all the time, and she doesn't do anything except the fact that she's disturbing me. Yeah. When we have assessed her, she said, the man, he is in love with me. And I love him. Yeah. This is called Clerambault syndrome. Do you know this?
erotomanic delusion. Yes.
Right. Can you answer the questions now? If you can.
The following statements concerning the Clerambault syndrome are true. The person who is the object of the delusional belief is frequent focus of higher social status. ده صحيح. غالبا بيكون رئيس أو حد كبير أو دكتور أو ممثل أو حاجة زي هيك. A patient usually a man has a delusional belief that someone in
يعني جونيور دكتور مع سينيور كونسلتنت مثلا، طالبي مع طالبي مع التيتشر هيك. طيب نمبر بي. A patient usually
غلط.
a
مش شرط
man.
تكون مان، مش شرط، هو يعني عادي يا مان أو women، وغالبا بتكون ست يعني.
بيكون ست بالضبط.
The patient often craves for sexual relationship. ممكن، بس مش هو الشرط يعني. بتكون غالبا بدها
والله
تحس انه بحبها.
it's essential. هو كل الحكاية حكاية sexual relationship. يعني the aim of the whole story is to have a sexual relationship or marriage or whatever. بس it's true. The patient often craves.
تمام.
Yeah.
تمام.
It has
إيريتومينيا طبعا اسمها إيريتومينيا هي إيريتومينيك delusion. the person selected is often much older than the patient. لا مش شرط.
لا it's short.
شرط؟ والله.
شرط أساسي. هو عادة
تمام.
هي زي ما قلت لك، يعني هي كان عمرها 25، هو هذاك المان كان in his 50s. In fact, some of these arrangement, it can go ahead, but the people, they will be critical of the fact, the difference in age. The difference in age بتكون huge.
لازم
يعني
يكون أكبر منها يعني بسن كبير يعني، ولا
سن كبير؟
يعني فترة كبير. تمام.
سن كبير.
شكرا.
يعني الفرق في social aspects of life like status and the age, it's a huge, it's big.
تمام. شكرا دكتور.
وهدول الريفرنسز.
ممكن أسأل سؤال بعد إذنك حضرتك؟
دكتور وليد، ثاني الدكتور وليد.
نعم تفضلي.
شكرا دكتور، يعطيكم العافية بالأول على المحاضرة، شرحها رائعة يعني. بس بدي أسأل في مريض جديد أنا شفته، هو يعني كان جاي لي بكلينيكال بيكتشر تشيف كومبلينت انسومنيا له 3 شهور يعني، وحسب ما قعدت مع دايجنوزز يعني حطيت ديفرنشال غالبا ميكست يعني افكتيف ستيت. هو المشكلة إنه المريض أصلا عنده ميديكال ديزيز اللي هو HIV، قبل 4 سنين اتشخص فيه، وكمان عنده مشكلة في العين، ضمور في العصب البصري أو حاجة. المهم يعني مرض إنه غالبا توصل لبلايندنس يعني، بس بالتدريج وملوش علاج حتى الآن يعني. فبدأ علاج بأولانزابين، ويعني كان هو أصلا البيكتشر اللي جاي فيها أكتر حاجة إنه الإنسومنيا واللو مود، بس في ريسنج ثوت كتير وأفكار كتير، بيحكي بس مع العقل الباطن ضلوا يتكلموا وهيك يعني، إنه أغلب الوقت. وكمان إنه بريشارد سبيتش يعني، وفي عنده شوية مشاريع بيفكر فيها وبده يعمل، بس بيستنى إنه يعني تحسن حالته. فلما الأولانزابين كان تمام يعني، حسنوا بنسبة 70 ل 80%. بس بعد هيك للأسف ماخد الأسترال لمدة 3-4 أيام، رجع الديستراكتابيليتي والأنسومنيا، رجع تاني عنده بسرعة العقل الباطن. بيقول لي لدرجة أن العقل الباطن بيجيب لي قصص قديمة وقصص حديثة وبيقعد يتكلم، وممكن أحيانا يعني أسمعه بس مش ترو هالوسينيشن، يعني سودو هالوسينيشن. فمش عارفة يعني حاليا بفكر أضيف له مود ستابلايزر، فكنت أديله ديباكين، بس للأسف عشان موضوع الإيدز يعني حاليا فما قدرتش أحطه، يعني لأنه بالذات بس حاليا هو الإيدز يعني كويس، يعني مستواه كويس، والآي سي دي 4 تمام، وعمل سي تي برين يعني قبل فترة وكانت تمام وفي كمان برضو مشكلة عنده غير هذا الكلام، يعني هذا كله إنه ما جاته كابوسي ساركوما وأخد علاج برضو مناعي وتحسن. فمش عارفه لقيته كمود ستابلايزر، يعني استشرت حد حكى لي اديله يعني اوكسا كاربامازيبين، يعني في افضل حاجه يعني في الحاله هاي، بس ما استجابش عليها. يعني اخذ 300 مرتين، يعني 150 الصبح 150 بالليل لف... لاسبوع، بعد هيك زادت ل 300 مرتين في اليوم بس ما تحسنتش يعني. فممكن اشوف راي حضراتكم يعني.
كاربامازيبين ما جربتين؟
كاربامازيبين لا، لانه عشان مشكله الاي اللي عنده، علشان خاطر انه برضه ميتابولايزد في الليفر، وكمان عشان مشكله انه ممكن يعمل له بليرنج اوف فيجن كسايد افكت، فهو اصلا ما بشوفش غير بالعافيه يعني.
هو بليرنج اوف فيجن ما بيأثر، لأنه كل الأدوية بتعمل بليرنج اوف فيجن.
صحيح.
يعني يعني تقدر تقول إذا ما الكربامازيب أوكس كاربامازيبين 150 ميكس يعني نو افكت. الدوز تبع الكلوكس كاربامازيبين هي ضعف الكاربامازيبين، فلا بد تكون الدوز مش أقل من 1200 ل 1800، أو بده يكون كاربامازيبين 800.
تمام، يعني حضرتك بترجح ان نستخدم الكربامازيبين، نبدا في
مهم.
جرعه 400 الصبح 400 او اقل شويه، بعد كده نوصلها ل 800 ل 1200. تمام، شكرا كتير يا
طيب،
دكتور.
يعني بالنسبة للسؤال عن الأنتي دايوريتيك هرمون، الواقع هو الليثيوم ما بيزيد أو بنقصه، هو بيأثر على الريسبونس اوف كدني، يعني النفروجينيك دايابيتس انسيبيدس يحدث نتيجة النون ريسبونس تو أنتي دايوريتيك هرمون، وبالتالي non response to dairy هرمون ممكن يؤدي إلى زيادة إفراز الأنتي دايريتيك هرمون as a feedback mechanism.
نعم،
شو رأيك دكتور أمين؟
صحيح كلامك صح 100%. هو الحقيقة النفروجينيك انسيبيدس بيز على هاي الثيوري، انه ديستال تيوبال نفرونز هم اللي بيكونوا افكتد،
صحيح.
مش الانتي ديوريتيك هرمون نفسه يعني.
مم.
يعني
تمام. شكرا جزيلا دكتور أمين على هذه المحاضرة الشاملة الوافية، وشكرا على العرض السلس المتناغم. شكرا للحضور، ونلتقي في محاضرة أخرى إن شاء الله. تصبحون على
تسلم
خير.
تسلم دكتور وليد، مع السلامة.
نعم.